introduce Dr. Oliger. So it's my pleasure to introduce Dr. Oliger today, who's an associate professor within the Department of Radiology. He obtained his PhD in medical physics from MIT and Harvard within the Division of Health Sciences and Technology in 2005, and then received his MD in medicine from Harvard Medical School in 2007. He then completed his residency in diagnostic radiology and fellowship in abdominal imaging at UCSF before joining the UCSF faculty in 2013. Dr. Oliger's main research involves the development and clinical translation of new MRI techniques for the abdomen and pelvis, with a focus on molecular imaging of liver tumors, liver metabolism, and liver injury. Current research projects involve using hyperpolarized carbon-13 MRI to image liver tumors as well as fatty liver disease. Dr. Oliger also has a major research effort together with Dr. David Wilson and Oren Rosenberg developing novel methods for imaging bacterial injection, which sounds very interesting and is something I know absolutely nothing about. So with that, I will let him take it away.
Excellent. Well, thank you very much. We won't talk much about bacteria infection today. I'm going to focus on the liver, but I'm really happy to give this talk. So I think generally, when Shreya asked me to give these talks, I think last year it was really radiology for the gastroenterologists, and I realized it was a really big area. So it really was important to focus on things that I think are important. And so, one second, I just have to click OK here. And so last year, I talked a little bit about MRCP and I think things like that. And then I realized that last year's talk is on YouTube. So I decided rather than give the same one again, I decided to shift the topic, which I think, there's a whole series, I think, of radiology topics that are important. I think good for gastroenterologists to know, and I think really enhance I think the collaboration between radiology and gastroenterology. And I think this one is actually pretty important. I'm going to talk about liver fat, iron, and fibrosis, and actually a little bit of quantitative T1. These are quantitative MRI biomarkers for chronic liver disease, and these are studies that get ordered all the time. And there are more and more now. And it's actually probably one of the bigger changes that's happened in the past 10 years in how MRI of the liver is practiced. And so I thought it's a really good idea to give you an introduction to what underlies these methods. And it's going to be a little bit technical, but I think what's important, because these are quantitative, I think it's important to understand where these numbers come from. And so first, I don't have any relevant disclosures. One thing I just want to do is I do want to I guess, give one disclosure and apology, is that I will be concentrating on MRI here. And I think in the broader scheme of things, when we talk about assessment of fat, iron, and fibrosis, and just the assessment of liver injury, we've had really an explosion of tools really in every area. So obviously there's other imaging techniques. So I think ultrasound has made a lot of strides in being able to do a lot of these things in terms of radiology, and even CT has keeps developing new methodologies, which I could talk about in another context if that was interesting to people. And then, of course, beyond radiology, there's been really an explosion of new blood markers and clinical decision tools that really assess a lot of these things. And so I'm not gonna talk about them, but it's not because I don't think that they're important. It's just that I think that I'm probably not the best expert in a lot of those tools, and probably a lot of people in the Department of Medicine are. And so I'm really going to focus on MRI, but really with the understanding that it exists within the context, really of just an exciting, I think, new armamentarium of things to look at within the field of chronic liver disease, and really something that is helpful for patients. And I think that's quite kind of exciting. So the five things, the five subject areas I'm going to talk about, and it's going to be kind of like skimming the surface on all of these because we only have like 50 minutes or so. First, I just want to talk about the notion of quantitative MRI and quantitative imaging in general. I think I think even for radiologists, it's really a different paradigm from what we usually think about. And I think it's important to shift into that context because it's kind of a different way of us looking at things. I'm going to focus on three things which are now really in routine clinical practice is looking at quantitative evaluation of liver, fat, iron, and fibrosis using MRI. And I'm going to talk a little bit about an emerging technique that has sort of started to catch hold, which is looking at what's called T1 mapping. And there's less data and there's less establishment for this, but it is something that people are talking about more and more. And so I'm going to mention that a little bit. And so first, just generally talking about quantitative MRI and liver disease, right? So first, just talk about what's the opposite of quantitative MRI. So it's actually almost everything that we do in imaging already. And so really most imaging interpretation is subjective and qualitative. A lot of medicine is subjective and qualitative. For instance, I mean, that looks bad, really. And this comes from experience, right? So I look at this thing up here in the liver, and this is in the right hepatic lobe, and it kind of is this sort of irregularly enhancing object back here. Now, it's true. It actually kind of looks ugly in some degrees, but when I look at it and when a radiologist looks at it, and just I think from years of training, I look at this and I'm like, I'm pretty sure this is a hemangioma. This is going to be benign, and we don't have to worry about that. And I look at this one and I'm like, wow, there aren't really good borders here. This is kind of a funny looking enhancing mass. I don't really see many things like this. And so I'm not even sure what type of tumor this is, but I think this is going to be bad. And so, this is kind of what we do, right? And so we said this is actually fibromegalar HCC in the end. And the truth is and I always put this in the introduction to talking about quantitative MRI is because quantitative imaging is not really taking over for these things. Despite the limitations, really, the fact that this is subjective, it's based on experience, we're really not assigning too many numbers to things. I'm kind of like, well, yeah, I've kind of seen this before. It actually works pretty well, right? So the last 50 years of radiology has really exploited this to a lot of advantage. Now, when we talk about quantitative imaging, we want to talk about the extraction of quantifiable features from radiologic images, right? And that looks like a truism, but it's important to sort of think about it, right? And so this is a liver, this is actually a uterus, and this is actually the rectum. So this is a patient with rectal cancer, endometrial cancer, and I think a liver metastasis. And so I think the best way to think of the quantitative markers is actually to think of ones that we use all the time. And it's actually size. And it's actually one that we don't really think of, but actually size. And specifically when we talk about RECIST, where we sort of talk about like exactly how you measure things, exactly how we're going to follow things, is really one, trivial, but actually commonly used example of a quantitative biomarker. And so like, for instance, and you all may be familiar with this idea of like RECIST and its variants, which are like mRECIST, which is used in the liver. And for instance, this is just really a specific protocolized measurement of how we measure size, right? Instead of kind of qualitative, where I'm kind of looking at it and I'm like, yeah, it looks a little bit bigger than before, or I kind of figure out like what kind of things about the tumor I want to measure. RECIST tells me exactly how to measure it, and therefore I hopefully will measure it the same way someone else will measure it, and someone else in another country or another place, or with different training. And that's really important, especially for clinical trials, but also when we're measuring things over time, right? When you're measuring things over time, maybe a year from now, maybe somebody else is going to measure it, and you want to make sure that things are comparable. And so again, this is really a simple example, but I think everybody has a conceptual idea of what size means. And so when you even think about specifying how we're going to quantify size and look at that over time, you can understand where the difference between, a sort of subjective and qualitative thing. The MRI is actually really special compared to other things like CT in terms of the features of quantitative markers that are available. So when you think of CT, so this is a brain, I apologize, but this is really illustrates what, the point that we need to make here is that CT has an absolute attenuation value. Is air outside the patient is negative 1,000 Hounsfield units, which is the unit of CT. Blood is about 50, right? And this is actually very standardized. And actually, when you do a CT, that's actually what you get. So the advantage is CT is already quantitative in terms of its attenuation. But the disadvantage is that when you do a CT scan, this is all you get. And so when we talk about liver fat, that's another thing that you can use for quantitative imaging features. MRI actually doesn't have a specific unit. in terms of its signal, and that's a good thing and a bad thing. The bad thing, of course, is it doesn't naturally come as a quantitative feature, but the good thing is it means that I can actually extract a whole bunch of different quantitative features depending on how I want to do it. And I'm not going to go through all of these, but I'm just showing you a list, and some of these you may recognize and some of these you may not. You've probably all heard of diffusion imaging, and this is definitely a quantitative feature in MRI. Not going to talk about that today. What I'm going to talk about is iron quantification, fat, tissue stiffness, and T1. But we could also quantify blood flow. We could quantify perfusion. We could quantify something else called T2, and in another time I can tell you what that is. And so there's a whole bunch of things that we can quantify in MRI, and we just have to choose the way we run the scanner or the way we put a pulse sequence together to emphasize one of these features or another. And that's really the great thing. And so when we talk about quantifying MRI, we can talk about chronic liver disease, which I think is probably, in terms of MRI globally, in terms of these sort of quantitative features, has been really one of the success stories, which is why I like to talk about it. And so, as you all know, this is an oversimplified method of like how sort of chronic liver disease leads to this sort of chronic cycle of inflammation and fibrosis, leading to cirrhosis and hepatocellular carcinoma. And I understand this is all oversimplified, where we have alcohol, fat, or viruses leading to this liver injury. And this will not be, the full disclosure also, this will not be the last oversimplified thing that I present today, but I think it helps to sort of conceptualize things. And so our normal standard imaging is really directed at these lathes, which is basically when someone has cirrhosis or someone has a tumor, right? We can sort of see a nodular liver. We can see there's ascites here. We can often see evidence of portal hypertension, like maybe the spleen is big. We can see some varices. And that's really our standard qualitative imaging, and actually does very well in sort of diagnosing end-stage liver disease. And then when people have end-stage liver disease, we're actually really, really, really good at diagnosing HCC. Actually, there's a whole series of lectures on LIRADS and other things we could talk about for that. And so actually imaging here really is well developed and it works really well. But in terms of like trying to influence management beyond influencing transplant or TACE or something like that, we pretty much have a patient where the disease process is at a state where everything is irreversible. And where we would want to actually intervene on, as I think you all know, I don't have to explain that, is really in this earlier stages of liver injury, right? Where hopefully we can find better ways to reverse diseases. But in terms of imaging, typically, if we don't look at quantitative biomarkers, really the liver just looks like a liver. And you can't tell the difference between a liver of someone who has inflammation or early fibrosis from someone who doesn't. And that's where these quantitative things come in. And so as it turns out, and this is why MRI is very specially suited to this task, is we can think of common disease features in patients with chronic liver disease. Again, an oversimplification, right? But as you know, here's our schematic of like some hepatocytes in there. And so, of course, one of the responses to injury is to accumulate fat, as you all know. Another response to injury is accumulation of iron, and eventually the development of fibrosis. And as it turns out, MRI has a quantitative marker, so a quantitative parameter for each of these. And so these are the disease features: fat, iron, and fibrosis. And the quantitative features, and I'll explain each of these in turn, really in the rest of the hour, is the following. And so for fat, we have something called proton density fat fraction, or basically fat and water separation, which is what MRI does really well. And so we can quantify that. For iron, we have a parameter. We're going to call it R2 star. This is a measure of signal decay. I'm going to tell you a little bit more about that in detail, but this is the number that we use. And then fibrosis, we have liver stiffness in the context of MR elastography. And so all three of these things are quantitative markers that sort of relate to some underlying disease process. And what is interesting is really that we're able to measure all three of these and really give a good picture of that. And so what I'm going to do is I'm going to talk about each of these in turn. I'm going to actually spend the longest time on liver fat because it really illustrates, I think, a lot of the general principles of our approaches. And so we'll go through that. And so actually, liver fat is actually can be diagnosed on almost every imaging modality. And actually, another version of this talk is actually just focusing on fat. You could spend a whole hour on fat and really talk about the whole ultrasound, CT, and MRI, and also other novel markers actually are sensitive to fat. So ultrasound, as we say fatty liver on ultrasound all the time. And here in this picture down here, I'm not going to talk about biopsy because you all understand about biopsies. When I look at an image, like, and so this is an image of the liver, and this is an image of the liver of someone who has a lot of fat. And how you can tell it has a lot of fat is, well, you probably have seen a lot. But you know, the liver actually is supposed to go all the way back here, but you see the sound beam is actually being attenuated. And this attenuation of the sound beam is actually what allows us to detect fat. Now, you might say, well, aren't there other things that will attenuate the sound beam? Yeah, 100% and certainly. And that's why many times, you know, you'll see sometimes in reports where it says it looks like fatty liver or other chronic liver disease, right? So a lot of processes in the liver can actually cause attenuation of this beam besides fat. But there are ways that we can sort of think about the differences with one another, but this is a very subjective interpretation. Now, this is a sort of keep an eye on this space because one of the more exciting developments in ultrasound is the ability to actually more quantify this attenuation and actually give quantified estimates of fat. And this is actually becoming available on ultrasound probably in the next few years as something that's standard. So that's going to be exciting. Happy to talk about that in another time. The CT, again, this is a way that we can actually quantify it. Actually works best for a non-contrast CT. This is and you can tell it's a non-contrast CT because there's no contrast in the aorta. But you can actually see these blood vessels, which is kind of interesting. The reason you can see the blood vessels is not because we've given the patient contrast. It's actually because the liver is very low attenuation. And it turns out that actually fat attenuates X-rays less than water does. And so by looking for a low attenuation liver, you can actually figure out how much fat there is. And this works actually really well and is relatively quantitative for high amounts of fat. The limitations are two things. One is this CT has radiation, and we rarely do CT without contrast. And you really need CT without contrast to do this very well. And also it works best for high amounts of fat. For low amounts of fat, there are a lot of things that affect the attenuation of the liver, and so therefore it's not quite as specific. And so that's limitations. MRI, again, and as I'll explain, is actually probably the best technique for measuring liver fat. And when I say best technique for measuring liver fat, like actually the best technique of any technique that is available, both radiological or otherwise for measuring liver fat. And the reason it's the best technique is simply that this is actually what MRI was born for. If you all remember in biochemistry and you did NMR experiments, you did spectroscopy in which you were trying to find the chemical composition of tissue. And when we try and diagnose how much liver fat there is, we're trying to find the chemical composition of tissue. And so this is really where, you know, where we have an application of MRI where it says, well, this is really what I do. And so I'll explain why that's been so successful. And so the most accurate way to measure liver fat with MRI, and again, I would argue probably the most accurate way to measure liver fat at all in other than, you know, taking the whole liver out and kind of melting it down is MR spectroscopy. And what we mean by MR spectroscopy is I can take an MRI scanner and I can take this little box. And just like you did when you did biochemistry or people who've done laboratory research and you try and characterize like what's the structure of a molecule using NMR, I can do basically NMR, nuclear magnetic resonance, on what's in this little box. And what you typically get, it's, you know, in the brain, you can actually see lots of little tiny things, but in the liver, what you usually see is you see one peak here, which is water, and you see another peak here, which is lipid. There's actually smaller peaks, which are also part of the lipid. There's actually one there, there's one there, and there's one there. That'll become important later. But really, by comparing this and this, I understand how much lipid there is. And this is probably the most quantitative way to really figure out how much lipid is in a tissue. Now, the limitation, of course, here is I'm only looking at a little box. This takes a while. Actually, though, on clinical scanners, like this is a Siemens scanner, we actually have this. You do a breath hold and you can get this in like 10 seconds, right? You can get these little boxes. Of course, it doesn't tell you what's happening in that part of the liver or that part of the liver or that part of the liver. Now, the reason I introduced this is the extensions, which allow us to look at fat in the whole liver, are all based on this. They just use a different feature. Okay, and so what I want to tell you about is something called, and this requires a little bit of inside baseball for MRI, is chemical shift imaging, and it comes from this frequency difference by basically what is it at a frequency? So as you may or may not know, when we do MRI, what we're looking at is we're looking at spins, which are little protons. They're like little bar magnets, and they're spinning around in a circle. And that's what's giving us our signal. The things that are spinning around the water, which is blue, and there's a little bit of fat, and they're both spinning around. By virtue of the fact that they're spinning with different frequencies, different periods, the fat actually spins slower than the water. So if we keep the water as a reference, and so even though the fat is a little slower, if I wait for a little bit, actually they kind of get out of what we call out of sync or out of phase with each other. And basically, you can imagine the fat is actually pointing 180 degrees from the water. And if I wait a little bit more, because this is going around in a circle, they kind of catch up with each other. And so you just kind of have to imagine it spinning, and then they kind of get out of sync, and then they get back in sync again. And actually, this is what we do. When I do a liver MRI, I get these images on every single scan, actually. And we get basically, and this is not even about quantifying fat. So you get one image because I waited a while, and that's actually the signal of water plus fat. And then we get another image. These are both T1 weighted images. This is water minus fat. And so this is out of phase and in phase. And this is basically standard MRI on every scanner. And it's a single breath hold. And it's actually the same thing we use for diagnosing HCC or getting contrast or anything like that. And so what this is actually very powerful, though, if we want to detect fat, because this is actually a patient without fat. This is actually a normal person. But if we want to take someone who has fat in their liver, this is the water plus fat. So this is actually the total signal in the liver. But if we take water minus fat, the signal decreases because there's a lot of fat compared to water. And so when we, in radiology, when we say that there's fatty liver or steatosis on a regular MRI, not one that's done for measuring quantification, this is what we're looking at. We're looking at what's called the opposed phase, when water and fat are out of phase with each other compared to in phase. And this by itself is an extremely powerful technique. Although the challenge here, of course, is this still doesn't tell you how much fat a person has. And therefore, if you wanted to follow it over time, you're not going to be able to do that. So the next thing we're going to talk about is the extension to this that allows us to tell how much fat and water there is. Now, the sort of enterprising among you who probably can see some linear algebra, you can already see some potential, right? This is water minus fat, and this is water plus fat, right? And so you might be able to like basically add these together. This picture was not supposed, ignore that picture, which is a poor animation. It'll come back in a second. But you can think about adding and subtracting these together, and you can actually do something with it. And so if you take something which is water plus fat and you add it to water minus fat, right? The minus cancels and you just get water. And you can do the opposite. You can take water plus fat and water minus fat, and you can add them together and the water cancels and you have something that's just fat. And so you can have an image that's just water and the fat is all dark. And you can have an image that's just fat and everything that is water is all dark. And so by itself, this is the most simple thing to do. And this is, again, what we do in every scan. We don't use this to quantify fat, but this is actually when we do pre and post contrast, because this image is fat suppressed, right? And there's actually, the fat is completely suppressed and it's uniformly suppressed. And this is actually a really good technique to do that. There are special names for these, and that's what actually we do all the time. Now, again, this doesn't quite work for quantification. And the reason it doesn't work for quantification, and I can't really, it requires a little bit more specialized MRI knowledge. The first is that there's the effect of iron. So actually iron will cause additional decays between these two images that are unrelated to fat. And we'll talk about that. Fat and water also have different relaxation properties. I'll leave that vague for now because I won't want to get into it. But actually what's very important is actually this just assumes that there's only one in the spectrum of fat, that there's only one peak that corresponds to fat, because that's where you're just subtracting them. There's actually several peaks. There's actually a dominant peak here, but sort of the other, like the CH3 things here, and there's a whole bunch of junk here, and there's another thing that's right next to the water. And we actually saw that when we saw the spectrum that we were looking at before. And so all of these things really keeps this method from being completely quantitative. So to make it quantitative is actually, and there's a little bit more math involved than I can go into, but what we actually do, instead of getting 2 images, we acquire 6 images. So we do it in a breath hold, and we actually acquire 6 images all with what we call different echoes. So basically 6 images that have been waiting different amounts of time. And so they actually will decay and they will also oscillate between each other. The decay, and this will be in the next part of the talk, is actually related to iron. The oscillation, which causes the signal to come back and forth, is related to the presence of fat. And so with really 6 measurements and then 6 equations, this allows you to measure fat highly accurately. It also allows you to measure iron highly accurately, but that's going to be in the next section. And so we get something that we call proton density fat fraction. And this you've probably seen or heard about. This is available on every MRI scanner. It is extremely accurate and reproducible. And you can measure patients over time, and you can measure patients between scanners, and you can get things that are really differ by a couple percent from each other. And so you get a nice 3-dimensional map. You can measure the regional fat. You can just measure whatever you want, or average fat, or anything you want to do. And it just gives you that very nicely. And then it correlates very well to MR spectroscopy or other things, even the presence of iron or other types of things. Why do we call it proton density fat fraction? And what that's acknowledging is the fact that what you're measuring are actually the number of protons that are parts of lipids. So it's basically the percentage fat within the tissue. Now, it's also acknowledging, I guess, technically speaking, that because there are some protons, there are some spins that relax more quickly than others, there are some that are MR invisible. So what we're looking at is the fraction of fat that's MRI visible. This doesn't really end up being very important in practice, but that's just where this funny name comes from, rather than just calling it fat fraction. It's PDFF. Now, there are a couple of things to know about it. So when you see in a report where I say that there's like 20% fat, and so this one would be like 23% fat, this is where this comes from. I want to talk, there's a couple nuances to this. One is actually comparing to histology. And so one of the challenges initially when this was being developed is it would be directly compared to biopsy or histology, because that's usually typically the gold standard of things. It ran into 2 challenges. One is, first of all, there's sampling error in histology, right? So you're just taking fat from measuring fat in one small part of the liver. And often when you do a biopsy, you don't know exactly which part of that liver it came from. And so when we were comparing the MRI values to the biopsy values, they didn't always exactly match up. But when you actually carefully match the measurements you make on imaging to where you take the biopsy from, they match up very well. The other reason they don't match up is they're actually measuring different things. And so when you do just a general grading of steatosis, right? And again, I'm going to oversimplify with apologies to the sort of pathologists out there. But when we're grading steatosis, what we're looking at is actually in a slide, how many of these cells have fat in them, right? So how much of this slide is fat? But that's not the same question that PDFF or MRI is asking. The MRI is saying, in an amount of tissue, what percentage of that is fat, right? And so the reason why that's important is that when you have, like, for instance, grade 3 steatosis, that's greater than 70%, greater than 2/3 lipids. But in PDFF, you never get greater than 67%. It's just impossible, because that's actually the total amount of lipids in the tissue. And so when we think of grading, what would correspond in PDFF is normal is less than 6%. Actually, it ironically comes from the value that's used in pathology. That's why people used it. But grade 1, which is mild, is actually 6 to 17%. And then 17 to 22%, which is sort of moderate, and then greater than 22%, which unfortunately we see quite a bit these days, that's very severe steatosis. And so, again, it is important to keep in mind that these 2 methods are actually measuring different things, and therefore the numbers are actually going to be different. But what you could do if you actually take a biopsy and you actually do like a chemical analysis of actually how much lipid is in the biopsy sample, which is kind of what MRI is measuring, the numbers you get are much more comparable. Okay, so there's a lot more to say about liver fat. This is my specialty, so I could spend several days just talking about it. But really, the summary is really MRI is great at this. It's actually what MRI was born for, right? Like, this is like, there's all this other stuff that it does. And even imaging is kind of like a little bit kludged. We like try and get together, but like separating different chemical species, that's really, 1950s, that was NMR. The fat in liver can be assessed qualitatively and quantitatively. So every scan we get, we do that in an opposed phase imaging. That's just, I mean, every abdominal scan has it. Actually, every pelvis scan has it too. But we can also, using this PDFF technique, measure it quantitatively. And the quantitative is probably one of the best biomarkers that MRI does, other than size. And it's because, you know, it just really it exploits some really important physical features of MRI, and it's highly reproducible and highly accurate. And many would argue that PDFF is probably the gold standard of measuring fat in the liver. You can't say that about any of the other techniques that I'm going to talk about today. Iron is getting there. Great. So I'm going to move on a little bit, and we can come back and questions later, but I want to talk about iron. So iron, I'm going to spend a little short time talking about it. Actually, the technique for measuring iron, as I sort of hinted at when I talked about fat, is actually even very similar to the technique that they're basically the same techniques. We just look at the different aspect. Now, of course, the importance of liver iron, and this is what you all know, and this is oversimplified. There's a great YouTube series about like different historical things oversimplified, and it's really awesome, actually. Better than my oversimplified. So the increased liver iron is really important for two reasons. These are why we want to measure it. One is that actually, obviously, iron deposition is a part of many chronic liver diseases. And so, you know, people develop cirrhosis or other things, you know, they gradually accumulate iron in the liver. But then we can think about the other part of it, sort of the hematologist point of view, is people with systemic iron overload, super high concentrations of iron. Liver iron is really a biomarker for total body iron. And so when hematologists order our sort of iron quantification studies, what they're looking at is an estimate of total body iron in patients with hemochromatosis or other things in which they're trying to decide whether the patient needs iron chelation therapy. And so these are the two reasons that we want to quantify liver iron. And iron is these little green things. Now, we do have qualitative iron imaging, and this is a patient with what we call hemosiderosis, which is just, you know, basically a patient who is gradually has acquired iron either through transfusions or even just liver cirrhosis. And the way we do this qualitatively, and I'll explain the physical method later, is that this is our normal imaging. So this is a T2 weighted image, and you can tell it's a T2 weighted image because there's sort of high signal here in the CSF, but the liver is super dark. And so iron actually makes the liver super dark on qualitative imaging, on T2 weighted imaging. The other thing we can see is there's iron in other places. You can see actually the bone marrow has iron deposition. This is just a patient who's had a lot of transfusions. And the spleen has a lot of low signals. So sort of both the low signal on T2 weighted imaging, as well as the pattern of that low signal, helps us diagnose someone with hemosiderosis. We'll talk about hemochromatosis in a second. The in and out of phase, which, you know, and I'll just leave this here without further explanation, but we could talk about it in more detail at some other point, actually has a funny paradoxical relationship. Is actually the iron. So I talked about when you have fat, the opposed phase image is actually darker than the in phase image, right? And that's because this is the opposed phase image is fat minus water or water minus fat, and they subtract from each other. Well, when you have iron, you get the opposite behavior, which is actually the in-phase image is darker than the opposed phase image. And that's actually how we diagnose iron. Now, you can see that's a contradiction, is why we needed PDFF, because if you have both fat and iron, these two things can cancel each other out, and they do sometimes. And so that's qualitative imaging. Another example of qualitative imaging would be sorry, this is supposed to have a title, and this is someone with more hereditary hemochromatosis. And so again, we have that in-phase and out-of-phase imaging. This patient also has cirrhosis. You can see the nodular liver. But you see here, there's less deposition in the spleen. There's less deposition in the bone marrow. There is some deposition here in the pericardium, which is kind of interesting. And so basically, this is another pattern of sort of qualitative. This is in a patient with primary hemochromatosis. It really doesn't allow us to quantify how much fat, but by the pattern of fat deposition, iron deposition, it allows us to say things about it. So now, in order to quantify it, I need to say a little bit about what iron does to the MRI signal. So again, MRI and iron are sort of like also really complementary, because Iron is like ferromagnetic. I mean, if you all played with little iron filings when you were younger, right? And you put a little magnet there, and all the little iron filings would line up with the magnet, right? And so they create their own little magnetic fields, right? And so even on a microscopic level, all of these iron particles, which are those little green things, are creating their own little tiny magnetic field. So if you think about a proton that's giving us our signal that's sort of spinning around like this, the magnetic fields that are coming from these little iron particles are actually interfering with the big magnetic field that this proton is feeling. And so actually, even any normal proton is actually going to have some signal decay over time. It's going to start off strong, and then it's going to get a little smaller and smaller and smaller by different physical processes. But if you actually put a little bit of iron, you can actually get a faster decay, that's why the images look darker, particularly on T2-weighted imaging. And if you have more iron, and so this is actually dose dependent, if you have more iron, the signal decays even faster, okay? Now, this for a long time was an artifact, right? So like basically this was a limitation of MRI, right? You lose signal if you have iron in your liver, right? And you're like, I don't usually want to lose signal. But if you think about how quickly you lose signal, and there's a parameter called R2 star. That's basically the decay rate at which you lose signal. The decay rate actually goes up as you have more iron. This is another example. So this is basically different MRI scans where I wait different amounts of time, 4 milliseconds, 9 milliseconds, 14 milliseconds, 21 milliseconds. This is a patient with a lot of iron. And you can see the liver is getting darker as I wait longer. And if I plot the signal, it makes an exponential decay. And I can look at the rate of that decay, and that's something called R2 star. We could talk some other time why R2 star, it's called R2 star and not something else. But what's really cool about that is this is from a paper that came out recently that shows a couple things. What you see here are 3 plots. This is 1.5T, this is 3T, and this is 2.89T, which is actually the field strength of a Siemens scanner. GE scanners are 3T. I don't know why they're, the Siemens, kind of cheats you of that extra 0.11T. And what this is, all 3 of these are plots of what is this quantity called R2 star. And then on the y-axis is actually biopsy-determined liver iron concentration, milligrams per gram of dry iron, okay, of tissue. And there's a couple things. The first is that the R2 star is actually linearly related to the amount of iron in the tissue, which is extremely strong and powerful thing. And this actually was known for a while. And so what we can do is we can actually calculate, knowing what the R2 star is, what the liver iron, what the liver iron is. And so this is really nice. The other cool thing is it's linear at 1.5T, 3T, and even 2.89T. It turns out the slope is different. So the 3T has a very, has a faster signal loss with iron, but it's still linearly related compared to 1.55T. So I can use any of these field strengths and get the same answer. The other thing is this is from a multi-center study, Stanford, Johns Hopkins, UT Southwestern, and University of Wisconsin, and basically everything matches up. And so across field strengths, across scanners, and these are all different brands of scanners in different locations, we really get the same performance. And so again, something that MRI does very well is if we can find R2 star, we can actually quantify the liver iron concentration, and we can get to crazy high iron concentrations out here. There are published formulas for doing this, and then newer scanners are going to be able to actually take these published formulas and give you direct iron concentration maps. Now, how do we actually measure it? We measure it, practically speaking, using the same pulse sequence that we do to get the PDFF. If you remember, when I talked about these like 6 images that the PDFF acquires, there's this overall decay of those 6 images, which is actually R2 star decay. And this is actually how we correct the PDFF for iron. So when we correct the PDFF for iron, we also get a map of this R2 star. And so in a single breath hold, we get a map of liver iron, we get a map of liver fat, which is actually a really, really amazing technique. And again, this is available on every scanner. And so that's what we do. If you ask for liver iron measurements, iron in the liver causes signal loss. The rate of signal loss is linear related to iron concentration, and this PDFF signal simultaneously measures them both in a single breath hold. All right, so I'm going to go through liver fibrosis, and I'm going to go through this one way too quickly, and that's an apology on that one because there's a lot to say about liver fibrosis. This is kind of a little bit cutting edge in terms of both imaging as well as laboratory tests and clinical markers in histology. And so I'm just going to talk about, I'm going to talk a little bit about transient elastography, FibroScan, which you're all familiar with, ultrasound elastography, which is similar, just to contrast with what magnetic resonance elastography, because they're kind of different. So transient elastography is basically, as you probably know, a one-dimensional ultrasound. An impulse is applied to the outside of the tissue, and it's basically FibroScan, and basically you see what comes back. And liver fibrosis, the sound waves travel through the liver at different speeds compared to not liver fibrosis. Now, since this is one-dimensional, we're not making an image. We don't actually see the place that we're taking the sample from. But really, this is a simple, point of care technique, and as it's really in standard clinical practice now, has turned into something very powerful. Something in between MRI and transient elastography is ultrasound elastography, which is something that's being used more and more. The ultrasound elastography, the impulse is different, though. It's not the same thing as transient elastography, just two dimensions. You're actually giving a different kind of stimulation, still measuring how quickly the waves return. And you actually get these maps. Now you get maps not of the whole liver, still of a small volume of the liver, just that little patch. It's bigger than in transient elastography, and it allows you, and you take multiple samples, you take an average, and then you get sort of a value out of that. And again, this is influenced by edema, cholestasis, congestion. Lots of fat actually in the subcutaneous tissues can cause attenuation of the sound beams, which also can influence this. And so, this is sort of an in-between again, MRI and I guess the sort of transient elastography. But again, it's less expensive. It's available. And I think in those ways that it's very advantageous. And we can, again, talk in a lot more detail about just this topic. There's a lot more to that. Now, the main thing I want to talk about is MRE here, which is just a little bit more involved than that. So you have someone in the MRI scanner, and we actually have a little driver here that we take outside of the room, and this vibrates. And then basically there's a little air-filled tube, like a little driver tubing. We place this little paddle right over, it's actually over the rib cage. It vibrates, it causes the rib cage to vibrate, and the rib cage to vibrate, that transmits the vibrations into the liver. It's called the passive driver. And we do an MRI basically at the same time. Again, we're measuring these shear waves. So we're not measuring waves that are going that way. We're measuring waves that are shear, which are basically perpendicular to the direction that we're traveling. It's the same as in ultrasound elastography, but different than transient elastography. And so typically we do 4 slices. Sometimes we'll do 8 slices. We do it over the biggest part of the liver. And what the images you get are these fuzzy images that look like this. This is what the MRI gets. But we don't read these. This is just to make sure that we acquired it. Then the MRI does some math. And then when it does the math, it actually gets these wave fronts that you can see propagating from where the driver was placed. This is a shadow of where the liver was. And then from that, you get a stiffness map. And this is a patient with elevated liver stiffness. And so it requires this, and then to sort of get that map. And then I look at it. And you can actually see there's the spleen, which is a little bit more stiff, and you have other tissues. The other thing we get is a measure of confidence. So you see all these hash marks here. So the scanner, when it does its math, decides how confident is it in the calculation of fibrosis in a given place. And there are reasons why, for instance, it may not get enough signal, or it may not be able to determine it in certain locations. And in those times, these little hash marks will actually take up more and more of the liver, and we make sure we measure it in a place where the hash marks don't agree. And so this is a classic case with a little bit of fibrosis. And so we can actually get a spectrum. So this is like mild to moderate fibrosis in different levels as you get more and more. And then advanced stage fibrosis is a higher liver stiffness. Now, this is 3.2 kilopascals, and then kilopascals is really the measure of liver stiffness. Now, how do we assign kilopascals to stiffness? So this is really a consensus. And so there are different ways you can do it, right? And so it turns out that all liver stiffness measures do mostly a good job of distinguishing milder fibrosis from advanced fibrosis. They don't do a great job, any of them, transient elastography, ultrasound, MRI elastography, of differentiating stage 1 to stage 2 or things that are right next to each other. And there are different ways you could acknowledge that. One is you could just arbitrarily just give cutoffs, right? Stage 1 is here to here, stage 2 is there to there, stage 3 is there to there, stage 4 is there to there. You can group them together in different ways. And there's a lot of sensitivity and specificity analysis that goes into it. A consensus from our sort of Society of Abdominal Radiology is, and the Mayo Clinic who sort of developed this technique, is really to sort of group things in really relatively easy to remember stiffness levels. But then when we think of the stages, we're not really saying this corresponds to a single stage. It really requires to an overlap of stage of fibrosis. And this comes to also the difference. And again, this is really true of any of these methods between blood tests, between imaging, is that fibrosis is a disease process, and it's more than just collagen, right? It's something that the pathologists are looking at, and they're grading it by both the architectural pattern and other things. And what we're measuring is stiffness, right? And the translation between collagen to stiffness is direct, but it's not exactly proportional, and it's not exactly linear. And that's why it's important to keep those in mind when we think about what the underlying disease is and what the stiffness is. The true biomarker is the stiffness that we can follow over time, whereas the staging is really something, it's sort of a surrogate for what we will find on biopsy. So that was way too little talk about MR elastography, and I'm happy to chat about it a little bit more. But we can get our stiffness measurement throughout the whole liver in anywhere between 1 and 4 breath holds. So again, this takes about 20 seconds. Each breath hold, it takes about 20 seconds. And so you're talking about a scan that really takes about 3 minutes, right? And then if you add in the fat and iron, you're talking about a scan that takes 5 to 10 minutes. And that's of the time that you're in the scanner. So it's very fast. It's standardized. It is also standardized across vendors and field strengths. It is confounded by a lot of the same things that other stiffness measurements are. So if you have acute hepatitis, that's going to make the liver look stiffer. Patients have to be fasting. So fasting eating will cause increased portal flow, which will also cause the liver to be a little bit stiffer. So acute hepatitis is a big effect. Non-fasting is a smaller effect, but it still exists. I'm going to spend 4 minutes talking about T1 because you may or may not hear a lot about T1 in the next couple of years. You may have already heard about T1. And some of those reasons are commercial business interests have sort of made their ways into this. And so we'll talk about it a little bit. And so first, I just want to talk about a departure. So in the 3 techniques we looked at, fat, stiffness, and R2 star, there's really almost a pretty direct correlation to the underlying disease processes. These are steatosis, fibrosis, and hemosiderosis, iron deposition. So the biomarker and the process match pretty carefully. With T1, which is this emerging technique, I'll talk a little bit about what it is. There isn't that direct connection, which is one of the reasons is a little problematic. There's more of an indirect connection. So T1 is also what we call a relaxation. And what you can think about it as like a spring. So if you take a spin and you're like, okay, I'm going to move it off of its axis, like a proton or something, eventually it's going to come back and line up with the main magnetic field. The rate at which it does that is called T1. And that really is influenced by the different things in the environment. And I can't really say any more about being vague like that. It's basically really just an influence of things in its environment, which is why it measures fibrosis. I'm showing this curve. This comes from cardiac MR, and T1 mapping was first established in cardiac MR, and it's most well developed in cardiac MR. And you can see here the myocardium of a patient, and you can see actually where they will reduce the signal and they will watch it recover. And this recovery, this sort of exponential recovery, is how T1 is measured. It's done in the liver in exactly the same way. And so what people notice is that T1 is influenced by a lot of things. It's actually influenced by fat. Like fat has a really short T1 compared to liver. It's influenced by iron. But another thing it's influenced is protein content. And so it's sort of a measure of protein content to some degree, and protein content is collagen, which is fibrosis. People are like, hey, well, maybe we can look at fibrosis. And so there have been a whole bunch of small studies to this date where people have looked at the correlation of mapping T1, which is actually, for instance, here, mapping this quantitative T1 value and comparing different measures of stiffness, either comparing it to biopsy, in this case, comparing it to MR elastography, where they get a nice relationship, and actually showing that actually, as you get more and more fibrosis, you actually have T1 goes up, and that's really great. And the nice thing about this is it does not require, unlike MR elastography, a vibrating panel. What's challenging about it? Well, the challenging thing about it is without further explanation, T1 is influenced by a whole bunch of things. It's influenced by fat. That's probably the biggest one, is because fat T1 is much, much, much shorter than the water T1, which is regular liver T1. So if you have increased fat, then your T1 is going to go down just by itself. If you have iron, your T1 is also going to be affected. It's different at different field strengths because this is, different things relax at different field strengths. So people have come up with better ways of measuring them, but the truth is, it's just not as standardized. There is a company though that has really stepped into the space. It's called Perspectum, and this company has come up with a parameter that they call corrected T1. And I just want to take a little bit about what corrected T1 is. And I don't totally hate it, but I also don't totally love it. It sort of tries to correct for this lack of standardization. And so what they did is they actually measured a lot of data and they introduced correction factors of this T1. And these correction factors corrected for scanner type, field strength, and actually the iron in the liver. And so, and then they give a CT1 value. And so actually they've done some studies where they correlated again these corrected T1 with different levels of fibrosis. And actually in these sort of small initial studies, they look great. Now, the challenge with this is, first of all, this correction is proprietary. So the formula for how they correct T1 is I don't know, but I can tell you what T1 is, and I can tell you how to measure it, but I can't tell you how to measure corrected T1 because it goes into their black box and it comes out that way. That's what they do. The other important thing, I think, for liver disease is because these people originally started with cardiac T1, they don't do any correction for fat at all. And it's interesting, and it's interesting how that affects their data because there is no, but people are working on other methods for this, and I'd say just keep an eye on that space. So I'd say that it is important. It still remains to be seen how important it's going to be. I think the people in Perspectum who also charge a lot for doing this processing, they basically charge for every one of these scans, and they actually charge more than we charge for reading the MRI scan itself. And so they're happy to tell you that it's really great, but I think it's still making its way. So quantitative MRI has been going on for a long time. This is an article in Radiology saying that biomarkers are really important, but this is from 2003. But really in the liver, things have really, and then we have to do a lot more to say what's normal. Could talk about that. We have to account for technical variability to make sure these markers are the same in every scanner, in every place, and every time that we measure the patient. But particularly in the liver, these have come a long way. So quantitative liver MRI is here, actually, and these are ordered. You guys order them all the time. It has an increasingly important clinical role. It does play especially fat and iron, which I think are probably the best biomarkers that MRI does. I think that's where MRI doesn't really even have any competitors. These measurements really, because they play to the strengths of MRI, they just really are actually what MRI does. MRE, which is, I think, in between, it does play to a little bit of the strength of MRI, but it is standardized across vendors and is in routine practice. Quantitative T1 is emerging. I think the jury is still out. It does require better standardization and better clinical validation. But all these tests, and again, this is what I started with, and you all know that, really this space, which is assessment of chronic liver disease non-invasively, has really seen an explosion of tools, both radiology-wise, so ultrasound has really made big advantages in this, and also non-radiology-wise, so cell-free DNA, other blood-based biomarkers, other clinical decision tools. And I think how to put all of these together is something that is still remains to be seen. But I think that's something that is extremely important because, these diseases are there's a lot of people that they affect, right? And it's not going to be one technology or one test is going to be part of everything, right? These all work, going to work best in their overall context. So I ended up using the entire time. I didn't leave a whole lot of time for questions. I know you have another talk to come, but I wanted to just thank you for your attention. I hope this was helpful. Definitely reach out to me if you have any questions. And yeah, and I look forward to seeing you in the reading room and I guess throughout the next year.
Thank you so much for that